All right. So I'm going to finish this thing up talking about non-operative treatment for shoulder instability. All right. We're going to maybe be a little bit more specific than some of the general instability in the shoulder when we talk about some of these treatment methods and exercises and so forth. Just to throw out a few terms, some of which Dr. Spirit already talked about, hypermobility and hyperlaxity in and of themselves aren't necessarily pathological. As a matter of fact, most overhead athletes who perform at any level need to have this hypermobility and hyperlaxity in order to compete at that level. It's when those structures fail to provide the stability that they're meant to provide, and something causes pain as to where that instability becomes a problem. And that can be multidirectional, unidirectional, bidirectional. Causes of instability, just mention these. Congenital causes of instability: Ehlers-Danlos, Marfan syndrome, osteogenesis imperfecta, benign joint hypermobility syndrome. Not things we're going to talk about treating tonight. Most things that will be diagnosed early on, with the exception maybe of, depending on where you're treating and the individual's health care, Ehlers-Danlos. We may run into this treating young adolescents or young individuals in the clinic, particularly overhead athletes or young female athletes. And there's a quick screening tool. Now, keep in mind, all these are genetic mutations that affect the collagen fibrils within our body. So not just unique to joints, but everywhere that we find these collagen fibrils. So different than what we're going to talk about, what we've talked about previously. But I want to mention Ehlers-Danlos. There's a quick screening tool, the Beighton scale, that most of you are familiar with, not familiar with. It's a 9-point scale. Any score of 4 or above is subjective or considered to be positive for Ehlers-Danlos. And basically, you ask the individual to perform these different motions, and they receive a point for each motion that they can perform in a particular joint. So one would be you ask them to dorsiflex their pinky to 90 degrees or beyond. If they can do that, they get a point for either side. If they can oppose their thumb to their ipsilateral forearm, that's a point for either side. If they can hyperextend their elbow past 10 degrees, a point for either side. Hyperextend their knees 10 degrees, a point for either side. And then if they can reach the floor with their palms, with their knees straight or hyperextended, that's 1 point. So a potential 9 points, again, 4 or above being positive. Just to mention that because you may run into that, chances are not, and then that'll be the last time we talk about any general causes of instability. What we're going to talk about more tonight are these acquired causes of instability, particularly in overhead athletes through their training as they develop, as they play the sport. Pitchers, definitely swimmers, volleyball players, they're going to develop this instability that they need to perform their sport and at particular positions potentially in order to perform well. You can also see it in occupations that require a lot of overhead activity, repetitive motions, and then traumatic dislocations, which Dr. Spear talked about. So we're going to talk more about these overhead athletes with the remainder of our talk this evening. So common characteristics: young overhead athletes, oftentimes females, present with instability more often than males do. They're going to present with unilateral slipping and unilateral symptoms. And this idea of joint slipping, or the individual being aware of their joint being loose or unstable, may or may not be the case. There's been a few studies out recently that caution individuals to look more closely at instability, whereas these patients may not be able to exhibit or even be aware of the fact that their shoulder is unstable. So any young athlete that has this chronic shoulder pain that doesn't seem to resolve with treatments or anti-inflammatories, that sort of be suspicious of shoulder instability, even if their subjective examination doesn't reveal anything that might cause you to be suspicious about that. Dead arm syndrome, you're going to see this in pitchers primarily in the late cocking phase of throwing. They report they get back and all of a sudden their arm feels like it goes dead or just gets really heavy. That's a symptom that typically is going to be unique to baseball pitchers and some other overhead athletes that get in that position. With these folks, they describe that sort of symptom. You want to be careful to screen for any radicular pathology as well as and or thoracic outlet syndrome to make sure you're not dealing with something else going on there as well as in conjunction with instability. And their pain is going to be diffuse typically with these individuals. So again, having this understanding of the pathoanatomy of the shoulder and the structures that provide the dynamic and static stability for that joint, I think, is essential in going into any patient that you're treating with instability, knowing when these different areas of the shoulder should or should not be restricting or providing stability for that motion. As Dr. Spear mentioned, the capsule is going to provide the stability mostly at the very extreme ranges of motion, or where it should be. And different parts of that capsule are going to limit different directions of mobility. So having an understanding of that, as well as the role of the cuff and the labrum and how they all work together, is essential in dealing with these individuals that we suspect might have instability within the glenohumeral joint. Examination, obviously, in order to treat it, you first have to detect it. And I think identifying the cause of both the pain and the instability and differentiating between the two, because something's causing the pain. It's not that the shoulder is loose that's causing the pain. There's something else that may be causing the pain in that shoulder due to the instability. Things that may be leading to the pain, as Dr. Spear talked a little bit about as well, bursitis, that internal impingement, that impingement between the supraspinatus and the labrum. Classic impingement, as we typically see in the clinic, more related to the supraspinatus, the labral involvement, and then cuff involvement. But again, cuff involvement simply meaning that potentially with that internal impingement and with general impingement as well. So there may be different individuals may report specific concordant signs or motions that may lead you in a direction of what type of instability, just on the subjective exam, before you even lay their hands on them. They might say, that when I throw, it hurts. Okay, well, that might be anterior instability. If I go to push open a heavy door or I'm weightlifting, I feel my shoulder sort of shift. It's a little uncomfortable. That might be posterior instability. They pick up their luggage or a briefcase and they feel their shoulder kind of slip or give way. That might be indicative of inferior instability. But again, most folks aren't going to be able to tell you these things, particularly the individuals that are coming in that are young overhead athletes. So when looking at their active range of motion, obviously they're going to have pretty much all their active range of motion and then some, essentially. So what we want to look for is the glenohumeral and scapulothoracic rhythm as they go through these motions. Look for and identify any dyskinetic motion. So I think it's important to, the guys need to have their shirts off, women need to be in a gown or sports bra, something where you can visualize the glenohumeral joint and the scapula and how it moves, see if there's any hitching, any biomechanic abnormalities that might lead you in one direction or another, and also can allude you to sort of going one direction with your strength testing as well. So it's important to look at these shoulders physically while they're going through this active range of motion. Passive range of motion. Obviously, you're going to look for areas of laxity, and we'll talk a little bit more about specific ways to detect different areas of laxity, special tests, and so on. But then also areas of tightness, which might seem a little counterintuitive in regards to someone who has shoulder instability, but that posterior shoulder tightness is something that you don't want to miss during examination. And more often than not, with overhead athletes, particularly throwers, if they're going to have anterior instability, chances are they're going to have some posterior shoulder tightness as well. Not everybody, but more often than not. I think that's important, because if we go through the examination, we detect some instability and say, oh wow, this shoulder is unstable. We need to strengthen all these muscles around that shoulder to get that thing nice and tight and stable again. And we ignore the posterior shoulder tightness that may be causing that anterior shift to that glenoid, humeral head on the glenoid. Then we could be strengthening some of the muscles back there to help push that forward and not addressing that, causing them further instability and pain, particularly with those individuals that have internal impingement. So that posterior shoulder tightness needs to be examined and addressed if it's there. You can perform mobilizations in order to get a better assessment of joint laxity. And then this idea of the glenohumeral internal rotation deficit and its linked to posterior shoulder tightness, that the GERD was originally described by Burke et al. In 2013 in regards to overhead throws, and has been described in the literature and talked about for years up until now, and currently will be talked about. But there was a study by Tim Tyler et al. In 2010 that looked at 22 individuals that were diagnosed with internal impingement. They took those 22 individuals and they applied a multimodal treatment approach through physical therapy that lasted anywhere between 7 to 12 weeks. And they measured their internal rotation, their external rotation, their posterior shoulder tightness, and their pain. Of the individuals that returned to sport and activity without pain in their shoulder, there were 12 of those individuals. All of those individuals demonstrated significant change in posterior shoulder tightness, and their posterior shoulder loosened up. But there was no significant change in their internal rotation. So their internal rotation did not improve at all. But their symptoms resolved, their posterior shoulder tightness decreased. So what does that tell us? Well, I think that tells us that maybe with some of our treatment approaches, that we may not need to focus so much on trying to improve internal rotation specifically, but do more things to address the posterior shoulder tightness that's not just improving internal rotation. Because if you think about it, overhead athletes and someone who's not symptomatic, has no pain, they're going to have greater external rotation, less internal rotation. So when do we know when we're dealing with internal rotation deficit versus not, particularly in overhead athletes? Strength testing, one of the big things, obviously, that will probably be weak in these individuals. In the literature in conservative treatment for shoulder instability is very slim. And the stuff that's out there basically says strengthen the parascapular muscles and increase posterior shoulder laxity. So there's not much detail out there in the literature, but most often these individuals, particularly athletes, are going to have some weakness in the parascapular muscles, so that's where you're going to be looking mostly, as well as all the other surrounding musculature as well. One thing to note, that when you're testing the parascapular muscles, middle trap, lower trap, rhomboids, that sort of thing, it's not your average brake test, meaning that when you're applying that force and seeing if they can maintain your pressure and not move, there's oftentimes a shift that occurs in the scapula in order for that individual to gain leverage and maintain that position against your force. So if you don't have a hand on that scapula and you don't feel that shift, you might say, wow, those muscles are pretty strong, when in fact they're weak and they're making that adjustment to accommodate for that weakness. So it's a good idea to have that hand up there on that scapula so you can feel whether or not that individual is making that shift to try and gain some leverage on you when you're trying to put them into that position. Special tests for shoulder instability, there's a ton out there. I tried to pick the best ones, none of which are great, and don't have a great deal of research done on them in regards to likelihood ratio, sensitivity, specificity, and all that business. But basically 2 categories: provocation tests that produce pain and laxity tests. So the provocation tests include the apprehension test, the apprehension and relocation test, and then the anterior release or surprise test. The laxity tests are the Salamh sign, the hyperabduction test, anterior posterior drawer test, and the load and shift test. So we'll talk first about the pain provocation test. So this is the apprehension test. All these tests you may perform or seen performed in different ways. The way I'm showing you here, the way it was described in the literature initially in regards to the test. So individuals in sitting, the arm is abducted to 90 degrees, the scapula stabilized here, and they're brought into end range external rotation, and a positive sign is just if there's pain at the end range external rotation. Apprehension relocation test, same position, only this time in supine. Arm abducted 90 degrees. Take the patient into external rotation without your hand over the glenohumeral joint, and if they experience pain, you place your hand on their anterior shoulder with a posterior force, and if the pain resolves, it's a positive test. This is kind of redundant. The anterior release or surprise test, basically this time you're taking them through the motion with your hand on there first, applying that anterior to posterior pressure. You get back to their end range external rotation, and then you take your hand off, and it's, ow, that's painful, and it's a positive test. I don't like this test because it doesn't help me gain trust with my patients. So these are the instability tests, the Salamh sign. You're just looking for that gap there while you perform an inferior force on the distal humerus there. There's ways to grade that. We're just seeing that and comparing them bilaterally. Hyperabduction test. Again, individual is in sitting. Arm, you can start off with the arm abducted at 90 degrees. Scapular stabilization here, neutral rotation, and then you move their arm into further abduction with the scapula stabilized. If it goes beyond 105 degrees, it's positive for inferior instability. Anterior drawer test, so applying an anterior force here with the arm in 90 degrees of abduction, neutral rotation, scapula stabilized here. Anterior drawer test, and this is just you're feeling the translation. Whether you feel like it's too much play, not enough play, all of that. Posterior is the exact same, scapula stabilized, only now you're applying the force posteriorly. Obviously we're looking at posterior instability here, noting the translation. And the load and shift test is sort of a catch-all, where you stabilize the scapula, provide a load on the glenohumeral joint, and then you just move it into the different positions. You move it inferiorly, move it anteriorly, and posteriorly, and note the translation with that load on it. So it's basically just a way to, it's like performing mobilization, it's just to kind of get a feel for the joint laxity. All right, so we talked about the importance of identifying posterior shoulder tightness during the examination and addressing it if it's present. So in order to do that, we need to quantify that posterior shoulder tightness. There's different ways to measure it. There's different ways that have been proposed in the literature. Tim Tyler et al. Was the first one in 1999 to describe a way to quantify posterior shoulder tightness. He did it in this position here, in sideline. Obviously, this is the arm we're interested in looking at. The other one, hands underneath the head to assume a normal spine alignment. Scapula stabilized here, abduction to 90 degrees. Try and get neutral rotation there, and then move into horizontal adduction. And you note where you feel one of two things, either tightness in posterior capsule, or that scapula starts to shift or move against your force there, that stabilization, and the measurement's taken there. So this is 0 degrees, and as you move down, this would be 90 degrees here, 0 degrees here. The way Tim Tyler et al. Described it in 99, he used a carpenter square to measure the distance between the medial epicondyle and the plinth. The problem with that is you can't compare those measurements patient to patient because it's a linear measurement, it's not a ratio data point. So using an inclinometer allows you to compare the data, and it's also easy to use. You just use a Velcro strap along the mid-humerus where the inclinometer reads 0 there, and as you go further down, it approaches 90 or beyond. In folks who don't have posterior shoulder tightness, you would expect it to go, probably 90 to beyond with this. So this gives you a way to quantify that posterior shoulder tightness and determine whether or not your treatment approaches are making a difference in resolving the posterior shoulder tightness. And then the eval, at least for me, sort of ends with trying to get the patient to buy into what we're attempting to do. Because if they're not on board from the get-go, then it's going to be hard to keep them engaged during the treatment. And I think it's hard, especially for these young athletes, to get someone who can bench press 250 pounds to understand why we're working on muscles that they can't see with their shirt off, and how that's going to help their shoulders. It's hard for them to buy into that. So I think it's important to, at least at the very basic level, to let them understand that, these are the things that help stabilize your shoulder. It's not those bigger, larger muscles that you see in the mirror that you work every day in the gym. These are the smaller muscles, the muscles in the back of the shoulder, the rotator cuff. Talk to them a little bit about the capsule so they know that this is why I'm doing what I'm doing, and it's different than what I normally do, or chances are it is. Otherwise, they wouldn't be weak in those areas. So treatment begins first with trying to calm that shoulder down from the pain that it's experiencing. So it might be so painful that you can't do much with it. So then you want to control that pain, whether it be from anti-inflammatories, ice, and if it's bad enough, maybe taking that individual out of the sport until that shoulder calms down enough to get them back engaged. One of the hardest things to do is treat an in-season athlete who has an injury that would benefit from being out, but not knowing whether or not it's good enough to go in and play, and trying to bridge that gap. So there are times where you might need to take them out to let it calm down so you can start to work on addressing some of these areas that you found during the evaluation. And then you want to, once that calms down, get back to the basics in regards to strengthening that shoulder. Build that solid base of support, reduce that posterior shoulder tightness if it's present, and then identify and eliminate any poor mechanics that they may have developed either because of the injury or just through training that need to be addressed. So tons of ways to strengthen or help improve the instability in the shoulder, I'm just going to touch on a few. Chances are, if it's a young athlete, they're going to be able to perform internal and external rotation at 0 degrees of abduction fairly easily against a fair amount of resistance. So I'd like to get them out a little bit into some degree of abduction, not all the way up here, but maybe 40 degrees, and see if they can perform internal and external rotation against that resistance using a band, obviously not a weight, because that's not going to help much, in order to get that line of pull and see if they can keep that shoulder stable. If not, then we may need to spend a little bit more time closer in to build that stability. Otherwise, have them up here and try and improve that strength. Wise T's and arrows are a popular form of exercise to help strengthen those parascapular muscles back here. Obviously, it's just the positions that Kendall recommends us testing these muscles in, is the ones that you put them in to strengthen them. Working below, this would be the end range of that particular exercise. That's why I put on a ball to try and get more range of motion through there. Typically, they're not going to need any weight if you have them do 3 sets of 10. It should fatigue them out pretty well. Anybody who can take 10-pound weights and go through this, they're using muscles that I can't see, because you shouldn't be able to do that with those muscles back there. And then this is just a variation of the arrow. Typically, it's performed with the arm straight like this, but when working with overhead athletes, this is more specific to the type of motion they're going to go through, so I'll have them do more of a W to help improve that strength there as opposed to an arrow. This little series, which I call the shoulder series, is just 3 different motions: shoulder flexion, scaption, and abduction with light weights. Not just as a strengthening tool, but more for me as an evaluation tool. Once we have put some effort into trying to build that stable base of support with the cuff and the parascapular muscles, I'll ask them to first just, are you able to go through these motions 1 repetition without pain? If you can, great. Now we're going to add a little resistance, and we're going to try 10, 10, and 10 consecutively with no break in between. And what I'm looking for is at the end, they should feel fatigue. They shouldn't have any pain. If they're experiencing pain, that tells me that we're not doing, we haven't done enough yet to strengthen those muscles that stabilize that shoulder, because it's riding up a little bit and they're getting a little bit of impingement or something else is going on mechanically that's not allowing them to go through that motion with simply just fatigue and not pain or any biomechanical abnormalities. So this sort of is a test for me to tell me whether or not I need to spend more time with them getting that base of support stronger, or if we can start to do more functional stuff where, you know, the stuff before, that cuff is engaged in isolation here. Here, that cuff needs to be engaged while those larger movers of the shoulder actually move it in space against some kind of resistance. So it's a little bit more of a challenge. It's a little bit dynamic, but not as dynamic as it's going to get before they get back into sport. Scapular mobilizations. If during your examination you note that scapular humeral rhythm isn't what you wanted, or the scapula seems tight, this is just my preferred way to perform scapular mobilizations. Patient side lying, again, neutral spine with the hand underneath the head. This hand here, if you've got a belt loop, they just hook their thumb on the back of your belt loop, let it relax. That way you can have 2 hands to mobilize the scapula, and they're relaxed and not engaged and all that business. And the literature shows us that there isn't one particular, even if there's a direction that the scapula is tight, doesn't matter which direction you're mobilizing it, as long as you're mobilizing it, it helps to improve mobility and reduce pain. Anterior to posterior mobilizations, only doing this if we're finding that posterior shoulder tightness during evaluation to help improve that. A lot of different ways you can perform anterior to posterior mobilizations. I like this way for a couple different reasons, but I don't do it with the pre-positioning that you might see in some of the orthopedic manuals for manual therapy, because with these individuals, if they're getting any pinching in there, this is Hawkins-Kennedy test, right? Positive for impingement with pain. It's the same position that they recommend for pre-positioning before doing an anterior to posterior mobilization in this position. So if that patient has any shoulder pain related to that, they're going to have pain when I put them in that position, which means they're going to be guarded, and my mobilization isn't going to do a darn thing because they're protecting against that. So this position allows me to sort of tweak that. So if I move too far in and they get some pinching anteriorly, that's not what I want, so I'll move them out a little bit. And if I rotate it more internally and they get pain, then I'll bring it back out to neutral. and then perform my mobilization anterior to posterior this way. What you can see is my finger placement. These two fingers I like to have on the sort of the outside of the scapula, not the medial border, but on the edge of the scapula, to lift it up a little bit to give me just a little bit more room to move that femoral head down so the plinth isn't right flush against everything. And that way I can use my other two fingers too to feel what's going on back there, because I never like that empty. So that's AP mobilization for improving posterior shoulder tightness. The previous slide in combination with this is my favorite sort of combination to reduce posterior shoulder tightness. That's super effective if that's what's going on. So this is a horizontal adduction stretch, but with that scapula stabilized. Hand up here on the scapula, just kind of guarding this way, isn't going to do much for that scapula rotating that way. And just having it against the plinth and the weight of their body, just because of the orientation of the scapula, isn't going to do it either. That border of the scapula needs to be stabilized there against the plinth, and then push them into horizontal adduction. Guaranteed every time you take your hand off and move them past where you just had them, I don't really feel a stretch anymore. That scapula should be stabilized in order to be as effective as it can be. Same sort of concept goes along with asking them to do this exercise at home, which is a good exercise to help increase the extensibility in that posterior capsule. But what happens is, as you're doing this, your scapula begins to come out along with it too. So although they might feel a stretch posteriorly, and they might get a little bit in through here, what you're really moving once you get far enough over are the soft tissues between the spine and the medial border of the scapula, not the posterior capsule, which you're trying to target. So if you can get them up against the wall, block that scapula up against the wall, and then perform this, they're going to feel a different kind of stretch, and they're going to isolate that posterior capsule that you're interested in stretching. Not that this is a bad stretch, and folks who are really tight may not be able to perform this without some sort of pain or discomfort, without first getting some general mobility in there and then performing this, but that's going to get to the heart of the posterior shoulder tightness. So this is another sort of go-to stretch for folks with posterior shoulder tightness, and the thought behind this is that what's limiting internal rotation is also limiting horizontal adduction. As we talked about a little bit before, potentially, there's only that one study done by Tim Tyler, there may not be, in regards to the resolution of pain, may not be a big connection between improving internal rotation and decreasing posterior shoulder tightness. So this may not be the best way to go about trying to get that posterior shoulder to loosen up a little bit, and it's painful. If you've ever done it and your shoulder was tight, it hurts. It hurts to lie on it, it hurts to push it. It's just something you can't be too aggressive with. So in regards to strengthening, so we talked a little bit about building the stabilization in some of those core musculature, what I call core musculature of the shoulder, being the cuff and then some of the parascapular muscles. And these are just my thoughts, and that's it, whether right or wrong, is that I prefer to strengthen those stabilizers and those parascapular muscles individually before asking them to do things dynamically in conjunction with other muscles. Knowing full well that in sport and activity, muscles don't work in isolation, but I think they respond better to strengthening and building up a certain amount of strength, particularly when they're very weak, in isolation. And then you can begin to fuse these things together, working more in conjunction with some of those larger movers of the shoulder. So this is sort of maybe a little step up from the other stuff, but not really. This is a static exercise where you got either both hands or one hand on the ball, and just ask them to hold that position. Believe it or not, that ball wants to move, and that shoulder has to engage to stabilize it there. If they do it for long enough, they'll feel their involved shoulder start to fatigue real quick, and especially if you're doing it on both, where you'll feel the involved shoulder get fatigued a lot quicker than the other one. So this is sort of a basic, they can't really tolerate much when you have them do this. It's static, and they can work those muscles fairly well. The body blade, great tool. For those of you not familiar with it, it's just a big bendable piece of plastic that's weighted on either end. You can make one out of PVC pipe and put pennies in the end if you want to. And basically, you shake it back and forth, and the weight on the end wants that thing to move back and forth. So you've really got to engage those shoulder muscles to hold it steady and get any kind of rhythm out of that. If your patient's not coordinated, don't even pick it up because it's not going to work. Try it, or if it's not their involved arm, forget it. This one, a little bit more challenging. I like to use a weighted ball up against here as opposed to a tennis ball or something like that. Again, this is another one of those things that not only is good for strengthening, working on everything surrounding that shoulder, but it also gives me insight into how we're doing and strengthening these muscles based on their arm position here. That elbow starts to drop after about 2 or 3 throws, or they start to want to come forward to the wall. Those sort of things tell me that some of those parascapular muscles aren't strong enough to hold that back there, or that cuff's still a little bit weak. But this is a good exercise once you get past that, building that strength in those stabilizers of that shoulder and sort of detecting whether or not you've done a good job or they've done a good job of getting that shoulder stronger. This is again just the body blade, again trying to get closer to using more than just the shoulder. An overhead athlete, are they able to maintain that shoulder stability coming through, engaging now the pec, getting the core in there as well for rotation. So now we're getting closer to those sport-related exercises. Again, there's tons of these. I'm just throwing a couple out here. This one is a tough one. This is for one that you think, yep, I've thrown everything at them, and they're doing pretty darn good. Their shoulder seems pretty stable, and let's just see whether or not we're right. And that is half Bosu ball. This is just broken up here. Half Bosu ball. They're not going all the way down to push-up position. When you start off in that position, one hand off the Bosu ball, one hand on the Bosu ball, you come down, not all the way down, you come back up, and as you're coming back up, you switch to 2 hands on the ball, and as you're coming back down, you take one hand off the ball. So this is boom, 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 back and forth, back and forth. So if they can do this without pain and without sort of compensatory mechanisms, they're doing pretty darn good. So at this point, you've rendered that shoulder stable. It's good and solid. Those cuff muscles are strong. The parascapular muscles are strong. They can do all these other things that are sport specific that you've put to them, and they can do it all without pain. So now you're thinking, all right, let's get back to sport. Well, we're going to do them a tremendous disservice if we don't first evaluate their sport mechanics and what potentially may have brought them to this point initially. So was it something in their mechanics or a breakdown in their mechanics that may have led to this shoulder pain? So we need to analyze their form and evaluate that kinetic chain throughout, not just their shoulder. So their shoulder was the emphasis from the get-go. Now the shoulder is doing well. So if we just send them back out and not evaluate their form, there's a chance they might be back with a similar or same injury. Perfect example is a baseball pitcher. So you get their shoulder working well, but you don't see whether they're using good technique to push off the mound with enough leg strength, or if there's core weakness and they can't rotate. So if they're going to go back and throwing that ball at the same velocity, and they still have those decrease in strength in their legs and their core, something's got to pick up the load for that. So if the legs are weak, if the core is weak, and they want to throw at the same velocity, the brunt of that force gets thrown to the shoulder because it's the last link in that chain, or if they're not following through enough to give their arm enough room to decelerate after producing all that force. So that's sort of the last step into making sure that they're not coming back to you for the same problem in a couple of years, or hopefully not sooner. So hopefully, through all this, we're allowed them to return to sport better, not just in regards to their shoulder, but being more knowledgeable in how their shoulder works, what muscles they need to exercise. They have better mechanics, and their kinetic chain is stronger throughout in order to prevent injuries in the shoulder and other parts of their body as well. So not just looking at the shoulder, but the whole athlete. So with that, we're going to end it maybe a couple minutes late and open it up for question and answer.